Good evening, all, and welcome to the 11th edition of TMC Medalogs. And today we have another distinguished alumni from the US, Dr. Balaguru Duraisamy. He's a pediatric cardiologist. And I ask Dr. Tyagarajan, who is an assistant professor of cardiology at Madras Medical College, to introduce Dr. Balaguru to us and to the audience. Dr. Tyagarajan?
Yes, Venki. Hello, sir. Hello to everyone. Myself, Dr. Tyagarajan, Assistant Professor, Department of Cardiology, MMC Chennai, and practicing outside also. I am a TMC alumni from 93 to 99. So, regarding our distinguished guest today, Dr. Duraisamy Balaguru, he is a renowned international physician. He is working as a pediatric physician in pediatrics and congenital heart disease, Massachusetts General Hospital for Children in Boston. Also is an assistant professor in Department of Pediatrics in Harvard School, Boston. Regarding his academic qualifications, he was in TMC in 1981 to 86, I think, and MBBS. Then 87 to 89 in Stanley, he has done his DCH, and he went to UK. And from 1990 to 95, he completed his various trainings, fellows, and other things. He got the MRCP, and worked in various renowned hospitals in UK and London. And then he went to US from 94, 95. He was a fellow in New York School of Medicine, senior fellow, then resident fellow, all these things he has completed. Then now his academic qualifications are AB, apart from MRCP and DCH, AB in internal medicine, AB internal medicine in pediatrics and adult congenital heart disease, and AB pediatrics. And he is now working as an assistant professor in Harvard Medical School, Boston. Then he was previously as a standing faculty in Harvard Medical School. Then professor of pediatrics in University of Texas in Austin. Then visiting professor in our SRMC Poru. And he was an associate professor in New York UMDNS University and Tufts University, Boston. He was an associate professor. Regarding his academic positions, course director. He was a course director for pediatrics and congenital heart disease in academics in Boston. Then associate professor of pediatric cardiology in Houston. Then director of pediatric cardiology in Tufts University. And I am unable to introduce much of him. He has got a lot of credentials to his name. He has worked in various intervention programs in ASD accrueders and VSD accrueders and various conferences. His curriculum vitae is very long, very difficult to introduce. So that's we can give this podium to the Dr. Duraisamy Balaguru, our renowned guest. Thank you.
Thank you very much for that kind introduction, sir. I'm glad to be here in front of this very inspiring audience. Since the time I joined this group, it has been inspirational. I learn a lot. On a regular basis, I am saving the papers that are shared in this discussion group. And it is a very nice group. And I'm happy that I joined, and it is very useful. I hope this presentation will be helpful for everyone. The objectives are to review the epidemiology of cyanotic congenital heart diseases, then look at the mechanism and the basis of cyanosis in newborn and the different types of clinical cyanosis in evaluation of a newborn with cyanosis. And then a small sidetrack into this pulse ox screening for critical congenital heart diseases that's been introduced as an universal practice in the US and in other countries as well. And review one or two of these cyanotic heart diseases with little more detail. Then we'll see how much we can cover in this time. So it's the condensed presentation. We will hopefully cover all of the plans made for this presentation. So this is a well-known statistics. The incidence of congenital heart disease overall is estimated to be 8 per 100,000 live births in the US. The incidence of significant heart disease among the 8 per 1,000.
The voice is a bit low.
Volume is low.
See,
Is it better now?
I ask other people also because I'm getting.
Okay, let me correct it a little bit. Dr. Venkatesh also mentioned it. I switched the microphone. Is it any better?
Yeah, it looks okay.
Okay, all right. Okay, let's continue then. For now, if it is too low, again, let me know. That's also, I tend to move a lot, and so that may also change the audio quality. For now, we'll keep going. Let's see. The incidence of significant heart disease. So congenital heart disease, 8 per 1,000 live births, of which only 1/4 of them are considered significant congenital heart disease. The definition of that term, significant congenital heart disease, is if that requires some intervention, either cath intervention or surgical intervention within the first year of age, then it is called a significant congenital heart disease. And it's 1/4 of all those patients with congenital heart disease will be significant heart disease. Out of those, 3/4 of them present in the first month of life. And out of those 3/4, another 3/4 within that will present within the first week of life. So learning neonatology and understanding neonatology is an essential part of congenital heart disease practice. And then there is this another term that is introduced since the time the pulse ox screening was introduced, that is critical congenital heart disease. That has a different definition, which is when they require intervention within the first month of life, then it is called the critical congenital heart disease for that pulse oximetry screening of newborn babies. So there are different terms used: significant heart disease, and there is a critical heart disease. And we are going to talk about cyanotic heart disease. So CCHD can be mistaken as cyanotic. But here, whenever it is said as a CCHD in clinical practice as well, it's critical congenital heart disease, which is defined as requiring intervention in the first month of life. So what are the common congenital heart diseases? With all of these spectrum of heart diseases that we have, just 9 defects constitute 81% of the defects. Starting from the top in the order of incidence, is VST is the commonest, so 33%. AST 9%, PS, pulmonary patent ductus arteriosus 7%, coarctation 6%. So these are all acyanotic heart diseases. Tetralogy of Fallot comes in there at 6%, varies up to 10% of all heart diseases, 5 to 10%. Aortic stenosis, another acyanotic heart disease, and then transposition of great arteries 4%, and then AVST. AVST has several different names. AV canal is a common name. Endocardial cushion defect is a common name. These are all names for the same condition, and it is commonly noted in Down syndrome. So all of these 9 defects constitute 81% of all congenital heart defects, out of which the cyanotic heart diseases account for 30%. So out of which tetralogy of Fallot is the commonest. Next commonest is transposition of great arteries. And after that, all of these are all 1% each, roughly about 1% each if you see all of these. So, and another thing I put in the corner, 5 T's and 2 A's. That's a very commonly taught mnemonic to remember the list of cyanotic congenital heart diseases. 5 T's are the first 5 on in this list: tetralogy, transposition, TAPVR, total anomalous pulmonary venous return, truncus arteriosus, and tricuspid atresia. And then 2 atresias, but it can be multiple atresias. Almost every atresia, mitral atresia, aortic atresia, pulmonary atresia, or tricuspid atresia, all of them will be a single cyanotic heart diseases. If you have a valvar atresia of some kind, it's going to be a cyanotic heart disease. And then there is this last in the list, signal ventricles. It's miscellaneous group of conditions where effectively there is only one functioning ventricle, and that's single ventricles. That's not one type of disease, it's all multiple kinds of diseases. And then a few other rare conditions, L transposition, as opposed to the D transposition that we call just transposition, Epstein's anomaly, double out right ventricle, and so on. So that's the list, of which just the two of these are highlighted, and that we will review these two at the end of this presentation. Then the causes and the types of cyanosis in a newborn. Central cyanosis and peripheral cyanosis is the first largest classification. When we say cyanotic heart disease, we are talking about the central cyanosis part. Peripheral cyanosis is just there to realize that it can happen and it should be recognized as such. Let's finish the peripheral cyanosis part first. This increased extraction of oxygen in the periphery causes the peripheral cyanosis, and it's caused by sluggish flow in the extremities. This can be just physiologic in cold weather or after bath or a shower in a baby. But it can also indicate heart failure. That's the situation where the peripheral cyanosis is actually an ominous sign. Except that, this is peripheral cyanosis is a benign condition. Just as seen in the first two top pictures here, baby's hands are blue, but the baby is otherwise looking well. And similarly, perioral cyanosis is a feature of peripheral cyanosis. And then the central cyanosis in the bottommost picture here, it can be heart disease causing it or lung disease causing it, and a few other things. Polycythemia make somebody look cyanotic, even when they are not sick from anything, or abnormal hemoglobin can also do that. That's the central cyanosis. We'll look at it in a little more detail in the next subsequent slides. And then this phenomenon of differential cyanosis. Whenever there is differential cyanosis, there is cyanosis in one part of the body and not in the other part of the body. That's the general idea of the term. It's differential cyanosis. When it is there, it indicates that there is a PDA and the shunt is right to left. So that's an understanding. Differential cyanosis is caused by PDA and the shunt happening right to left. If the PDA is shunting left to right, we don't have a way of seeing that differential happening. So then we'll get to that. And then anemia. Presence of anemia makes recognition of cyanosis difficult. Here is an explanation for that clinical cyanosis. So this clinical cyanosis becomes evident when the reduced hemoglobin amount exceeds 5 grams per 100 ml. About 2 grams of reduced hemoglobin is always present in the venules of the skin. When you add approximately about 3 grams of DL grams per 100 ml of reduced hemoglobin to the arterial blood, then that 2 plus 3 makes it 5, and that makes the skin look blue. And if you have a normal amount of hemoglobin, you only need about 20% desaturation to reach that level of 3 grams per DL. But if you are anemic, you have to have an accumulation of reduced hemoglobin up to 50% to really show, to gather 3 grams of hemoglobin per 100 ml. If your hemoglobin level is 6 or 8 or 9, it's going to be correspondingly lower level of pulse ox saturation. And the opposite happens in the polycythemia patient. Supposing that hemoglobin is 20 and you have only 5 to 10%, 15% of desaturation, shows the accumulates 3 grams of reduced hemoglobin, and therefore cyanosis is readily visible. That's effect of anemia and polycythemia. Let's look at the differential cyanosis. This is a common presentation. You get called for a cyanotic baby, and it is routine nowadays to have preductal and postductal saturations displayed on our regular monitors, especially in a baby like this. So they also use it for persistent fetal circulation patients with a normal heart. So that is a case of pulmonary hypertension with a normal cardiac anatomy, and the same differential cyanosis will be noted in that situation. So pre-ductal saturation is normal and the post-ductal saturation is lower. And it is here nearly 20% difference between the two. And the differential diagnosis for this condition, for this situation, very simple. Thinking about it, coarctation with a PDA can do that. And the PDA in this situation is compensating for what is not coming through the coarctation. And the shunt is right to left. Therefore, it is bringing in the desaturated pulmonary artery blood flow to compensate for the coarctation and constitutes the descending aortic flow pattern flow. Similarly, in a patient with persistent fetal circulation, also called as persistent pulmonary hypertension of newborn, that's the new term for this condition. PDA is with the pulmonary hypertension shunting right to left causes this combination of features. And this is not just a newborn phenomenon. If the PDA is present and there is a persistent right to left shunting on that, and with time, minimum 6 months, clubbing happens. And this is a 40-year-old girl with the PDA and pulmonary hypertension, and she has 7% difference between the right hand and the leg, 97 to 90, and she's starting to develop a mild clubbing. And her nails, she has nail polish on her nails that are pink in color. And this is a 21-year-old with the same condition, PDA and pulmonary hypertension from Eisenmenger's complex. And he has 20% difference between the hand and the leg. And he's in a wheelchair because of polio that he had as a child. And you have clubbing in the feet and no clubbing in the hands. The hands are pink, feet have cyanosis. And this is differential cyanosis. So this is the cartoon showing the mechanism of that. So the arteries are from the aortic arch receiving the LV blood and the pulmonary venous blood that is normally saturated 97%, and then the PDA shunting to the right contaminates it and brings down the saturation in the legs. And then there is this phenomenon called the reverse differential cyanosis. The differential diagnosis for that is only one thing, transposition of great arteries. So the pre-ductal saturation is 80%, post-ductal saturation is higher. And this is a situation that can only happen if the aorta is receiving the blue blood. So what is meant for the pulmonary circulation is coming into the aorta. So that is transposition of great arteries. That's the reverse differential cyanosis. And this will now be seen in adults because it's not compatible with long life without repair. So just a case example to illustrate this point about pulse ox and differential cyanosis that can help. So it's a 6-day-old baby brought to the emergency room earlier. Baby had been discharged on day 3 of life, was doing well at that time. Currently, the complaint is lethargy and poor feeding for 1 day and signs of respiratory distress. There were no peripheral pulses palpable, poorly perfused, in shock state. Pulse ox, very poor signal, pulse ox, and we don't get a pulsatile signal, and we get a number 65% in the right hand. And the blood gas has a pH of 7.08, PCO2 of 30, PO2 of 25, bicarb of 12, and base excess of -14, and a lactate is elevated at 15. At this point in the emergency room situation, the differential diagnosis includes septic shock, congenital adrenal hyperplasia, and critical congenital heart disease. And the patient gets resuscitated in the emergency room, intubated, fluid bolus given, epinephrine drip started, the bicarb correction is done. Upper limb pulse is returned, but there was no femoral pulse. This is an important finding, that the physician was alert to check the pulses again after the baby was somewhat stabilized. Based on this, they started the prostaglandin, and cardiology was called at this point, and echocardiogram was done, and it showed coarctation. And that's in this picture. The picture quality is very poor, the echo quality, but here is the aortic arch. And when you see that there very small stream of flow going through the coarcted segment, and there is a tiny jet coming through the PDA. So the PDA has almost closed. What has happened in this patient is this PDA has remained open until this point, probably until about a day ago, and compensating for that coarctation, and therefore patient was apparently well. And on day 3, most probably this PDA was much larger and was producing a normal femoral pulse. Femoral pulse, absence of femoral pulse is taken as one indicator, and it's always looked for in postnatal checks, and that was misleading that it was present. But if we had done a pulse ox in the foot, we could have found this out. This case is from 2006, before universal pulse ox screening was instituted, which was in 2014 in the US. And the patient went through an ICU course, a period of anuria, elevated LFTs, coagulopathy, and seizures. So multi-system dysfunction, a gradual improvement over a week after stabilization and improvement. Coact repair via thoracotomy was done. And long-term outcome in this patient, the mild developmental delay at 2 years, and otherwise patient is doing well. So this is one illustrative case where this pulse ox screening could have prevented this patient from going home, and the apparent feeling of the femoral pulse, which is constituted by the flow from PDA compensating for it, could have been picked up by the drop in the saturation in the foot. And that's illustrated in this cartoon. We'll just go to the next slide. And somebody looked at these delayed diagnosis critical congenital heart diseases. This is from Great Ormond Street Hospital, where they looked at successive patients for a 3-year period, I believe. And the paper came out in 2006, where there were 3 groups of patients. The group A is patients who had the antenatal diagnosis of the heart disease, and group B is the postnatal diagnosis before discharge from the hospital, and then group C is postnatal diagnosis after discharge. 60% of them arrived in extremis, and 30% of them had presented with end organ dysfunction. So it causes significant morbidity. There was no significant higher death rate, so it's not mortality, it's significant morbidity. And this was reflected in their long-term developmental outcome. And so based on these, there have been studies here and there initially, and then in 2014 in the US, American Academy of Pediatrics endorsed this universal screening of all baby discharges from the hospitals with the pulse ox screening protocol. And that protocol from 2014 has gone through various iterations. What is normal, what is abnormal, what are the cutoff points for these saturation values. And this is the final one as it is now. This is published in 2025, just early part of 2025, but called the 2024 CCHD screening protocol. The first C is not cyanotic heart disease, it is critical congenital heart disease, because coarctation technically is not a cyanotic heart disease. That gets picked up in this. So it should be done after 24 hours of age, allowing time for the PDA to close in a normal baby, and a spontaneous breathing patient, room air, and it is done in the right hand as a representation of preductal and 1 foot. And if you go to the last column here, if both limb numbers are more than 95 or equal to 95, and the difference between the right preductal and postductal are less than 3%, then the person passes. The patient can be discharged or passes the CCHD screen. That's what you would say. On the first column here, if any one of the limb saturation is less than 90%, that's a fail, and it directly go to clinical evaluation of the patient. And then the in-between group here, 90 to 94% in one of the limbs, or the difference between the 2 values is more than 3%, then that should be retested after 1 hour. And after that, if you fulfill these criteria as in the third column, you are a pass. If not, you also go into the clinical evaluation group. And they should be originally the previous version of it. All of these patient clinical evaluation meant echocardiogram, not anything in between. X-ray, EKG, nothing. It's just echocardiogram. And that has been scraped off and they said clinical evaluation. Then somebody decides if an echocardiogram is necessary or not. So this is another study which really looks at the value of such a screening. And this is from 2010, before the 2014 implementation. This is one of the studies that gave the impetus for everyone to say this is worth doing. So universal screening. And it's a lot of data on this page. I'm just going to add some details that I created. This 2x2 chart, but here are the specific things. It's 77% sensitive, but 99.9% specific for something critical. And positive predictive value for critical congenital heart disease itself is only 25%, but negative predictive value is 99.9%. And if you add the number of cases that turn out to have normal heart with a pulmonary hypertension, persistent pulmonary hypertension of newborn, this positive predictive value increases to 53%. And then if you add sepsis to that, it increases up to 76%. So sepsis patients and PPHN patients also need special treatment, and they are critically sick patients. Therefore, overall, this has a very good value in doing. And this study comes from Germany, 34 hospitals, 48,000 newborn, 6,000 excluded, and then 42,000 ended up being the analysis group. And what lesions were picked up by this? So any duct-dependent systemic circulation, so truncus with interrupted arch or coarctation of any kind, hypoplastic left heart syndrome were picked up, otherwise asymptomatic at that point of diagnosis based on this pulse ox screening. Duct-dependent pulmonary circulation, pulmonary atresia of the VSD, that's a tetralogy pulmonary atresia patients. TAPVR, technically that we were surprised too. We see a number of TAPVR patients that are picked up by pulse ox. Transposition, two of them, and complex cyanotic heart disease of various kinds. Very interestingly, what was missed? Coarctation was missed. This is what we would want to pick up, or the theoretical part is coarctation will be picked up in this, but not always the case. And then complex coarctation is whenever coarctation is associated with another cardiac lesion, such as VSD, which is common association. VSD can play tricks on these numbers. Therefore, that could be an interesting explanation for why it was missed. Same thing, transposition with VSD also. Whenever there is an VSD inside the heart, the saturation becomes a little bit off from what you would expect based on theory. So out of all this, this is the analysis. There were 90 patients with heart diseases in this screened in this group, in this population. 60% of them were antenatally diagnosed. And another 20% by just clinical examination and suspicion, and that initiated further investigations. And so clinical evaluation picked up 20 more percent, so 80% is covered. And then the pulse ox screening added 15 to 16% of patients were picked up just by pulse ox screening. That's what is added by introducing this. And still, there is a 4% diagnostic gap remains. That's one of the still remains. This is now 11 years going since it was introduced, and still there is a 4% chance of missing something significant. So as a disclaimer for this training or pulse ox screening, that should be remembered. There are a few patients who can be still missed. And an important point to remember is, what are the heart diseases that are going to be picked up by this? It is not going to pick up any of the acyanotic heart diseases, VSDs, PDs. It is going to pick up multiple conditions. Now it is numbering 12. Originally, we started with only 7 conditions we thought will be picked up by this, but the others are also getting picked up. The TAPVR was a surprise one added here. Quite a number of cases are being picked up just by this screening. And then hypothermia, hemoglobinopathy, sepsis, lung disease, they are all, and persistent pulmonary hypertension, hypoxic conditions from other causes, they are also getting picked up. So these are all getting picked up from CCHD screen. Just because somebody has passed CCHD screen does not mean they don't have any heart disease. They just don't have critical congenital heart disease. And there is this, we always have to remember that 4% that is getting missed. So that completes the general use of that cyanosis in a newborn. And whenever a picture like this comes, that means I'm going to pivot to some other part of the topic. So this is a picture of the ether dome. And this building is called the Bulfinch Building, built in 1811, and part of Mass General Hospital. The hospital started in another building, but then this was built around that time, completed in 1820. And the top floor in this is an amphitheater, and it has the dome, and it's called the ether dome because this is where Dr. William Martin in 1846 on October 16th demonstrated the use of ether. And that day is celebrated as World Anesthesia Day. It's coming up in about 11 days. And it is, there will be usually a celebration in the ether dome on that day in Mass General Hospital. This is the inside of that ether dome as it is today. And there is that mural that we saw in the previous slide. Okay, we'll get to another case. The case of cyanosis at 1 hour of age. There's a term baby boy, 3.2 kilograms, good size, born in rural New Hampshire, no prenatal care, and routine resuscitation at birth, nothing special. But the UPGARs were 6 at 1 minute and 8 at 5 minutes. At 5 minutes, baby is otherwise well, has cyanosis, central cyanosis. That makes it -2 and therefore 8 UPGAR. By itself, it's not bad, but it is significant cyanosis. CPAP was started with using 100% oxygen in the labor suite. Pulse ox was 55%, and they were same in pre-ductal and post-ductal. That's an important situation here. After talking about the pulse ox screening, we'll come back to that later. Heart rate of 160, blood pressure is not too bad, 53/26, the mean of 36 millimeters of mercury. Good femoral pulse and the systolic murmur. So this is the phone call information. And the child was taken to the neonatal intensive care in that hospital, and they kept on ventilating using 100% oxygen, and the blood gas in 100% oxygen is this. pH of 7.28, 38, and 32 is the PO2. 100% oxygen, PO2 has to exceed 200 millimeters of mercury. So, and then bicarb is low, lactate of 12. And this itself is the hyperoxia test that is being done to differentiate between pulmonary causes and cardiac causes. And if it were a cardiac cause, the PO2 does not exceed 150 millimeters of mercury. And if it is a non-cardiac cause, like lungs or neurologic disorders, PO2 will exceed 200 millimeters of mercury in 100% oxygen. Key point is either the patient should be on a ventilator or on an oxyhood like this, head box like this. And it should not be done with just a nasal cannula oxygen, because you can never achieve more than 40% or so in nasal cannula oxygen administration. So it should be either an oxyhood or a ventilator. This has been done in the places where there is no echo facility. And the original paper comes from Mass General Hospital in 1975. And chest x-rays will help. This picture of hyaline membrane is really a bad case. The standard case of hyaline membrane disease, you will have a more generalized ground glass appearance with the cardiac silhouette showing up, but here it's much worse than that. And in our patient here, lung fields look okay, cardiac silhouette is normal. I would say it is normal. It's not cardiomegaly. Pulmonary vascular markings are normal for a newborn. So this X-ray is at least ruling out lung disease here. And the other finding that we can use in the chest X-ray findings for cyanotic heart disease, one is the cardiomegaly and the other one is the presence of pulmonary vascular markings, if it is decreased or increased. The mechanism of cyanosis in cyanotic heart diseases is either decreased pulmonary blood flow or blood mixing inside the heart. So right to left shunting, basically. So pulmonary stenosis or tetralogy flow, because pulmonary stenosis is part of tetralogy flow, and tricuspid atresia with PS. There is a situation where tricuspid atresia without PS can happen too. And then Epstein's anomaly, when the pulmonary vascular resistance is high in a newborn. Epstein's anomaly is listed under cyanotic heart diseases, but it is a transient cyanosis. There will be cyanosis as long as the pulmonary vascular resistance is high, which is normally high in a newborn, and then comes down, and then slowly the cyanosis goes away. So that's decreased pulmonary blood flow. On the other hand, you can have increased pulmonary vascular markings, typically in transposition of beta arteries. The X-ray I just showed you has normal pulmonary vascular markings. That can be acceptable too. Then truncus arteriosus will have increased pulmonary vascular markings if there is no associated PS. TAPVR, hypoplastic left heart syndrome, tricuspid atresia without PS, and single ventricle without PS. Here is tricuspid atresia with PS, tricuspid atresia without PS. So that modifier of PS comes in there. And then the cardiomegaly, large heart in Epstein's anomaly, pericardial effusion. This picture is an Epstein's anomaly patient in the bottom of the screen. And then dilated cardiomyopathy, congenital myocarditis, usually of viral etiology, or it can be of multiple other etiologies, and systemic AV malformations such as vein of Galen malformation. And ECG, limited value in making any significant diagnosis by itself, but it can give you features that you can use in the differential diagnosis discussion. One is the axis. Axis, if it is left axis deviation, that is always abnormal in a newborn. Newborn should have right axis deviation because RV is the dominant ventricle in the newborn, and then slowly LV becomes the dominant one over about 6 to 12 weeks. So, so the diagnosis, if there is a left axis deviation in a newborn EKG, the diagnosis is very short, differential diagnosis. AV canal or the endocardial occlusion defect, tricuspid atresia with RV that's very small, and LV that is dominant. And cardiomyopathy, I just put it as one diagnosis, but cardiomyopathy in newborn is a rag bag of multiple different cardiomyopathies from various reasons, including infant of diabetic mother. And you can see features of individual chamber enlargement that can be put into the discussion or consideration in making the diagnosis before an echo is done. But in complex cyanotic heart diseases, echocardiogram is essential. Fortunately, that needs to be done. So back to our case who had this cyanosis. This one frame of echo shows left ventricle connected to the main pulmonary artery, and that bifurcates into two. So the bifurcation, demonstration of the bifurcation is what identifies this vessel as the main pulmonary artery. Otherwise, it can just be, it just looks like a aorta. So this is LV, main pulmonary artery, and the branch pulmonary arteries. So this is transposition of great arteries. Here is a cartoon of a normal cardiac orientation and transposition in Netter's diagram. So aorta should be posterior, pulmonary artery should be anterior at the valve annulus level. That's the key point. That at the valve annulus level, pulmonary valve is anterior, aortic valve is posterior, and that is reversed. Aortic valve is anterior and pulmonary valve is posterior. So once it is reversed, it is transposition. And then the D or the L prefix is given based on which side of the pulmonary valve is the aorta. Here in this picture, you can tell aortic valve here is on the right side of the pulmonary valve. Anterior and to the right is the aorta. And that gives this designation D. When we just say transposition of great arteries, that always refers to this D when we don't say it. L transposition is the opposite kind, where aorta is anterior, but to the left of the pulmonary artery. That's a different disease altogether, and we will not discuss that at this point. So transposition of great arteries. And the key part is to understand the physiology of transposition. So normal circulation, and let's start with this picture. Let's look at a figure of 8. The normal circulation, where the now the venous return returns to the heart, and it is blue, and it goes to the lungs and becomes pink, and comes back from the lungs back to the LV and to the pumped out through the aorta to the body. So the pulmonary circulation and the systemic circulation are in series. It has to go back and forth, but in transposition, that doesn't happen. They go on their own without. This picture on the left side illustrates this. In any complex cyanotic heart diseases, the exercise to do is very simple. Imagine that you are the RBC and you are entering the heart. How are you going to go? So it can be a very complex tricuspid atresia, mitral atresia, or any of these cases. So you could figure out which shunts are necessary for survival. So here, imagine you are the RBC. This is transposition. You're entering into the RA, go through the tricuspid valve into the right ventricle. And then the valve here is semilunar valve, but it leads to the aorta. So RV to aorta. So the blue blood comes in, goes through the aorta, goes back to the body, becomes more blue than what it was, and returns to the heart, and then goes back again. So there is no oxygenation happening in this circulation. And on the opposite side, you have this left ventricle from which the blood goes into the main pulmonary artery, goes to the lungs, get more oxygenated, returns to the left atrium and then left ventricle. And then that circulation goes on its own, and the RBC can only become that much red. It can't become more red than 100% and some dissolved oxygen. And that's about it. In order for survival, there should be some way this can mix. So these are the two locations where you can have some kind of mixing. Patent ductus arteriosus or the patent foramen ovale. And these two are the locations that, for treatment purposes and stabilizing the patient, this is what we're going to do first. So baby will be born with cyanosis at birth, reverse differential cyanosis. This is an important point. This baby did not have reverse differential cyanosis. Sometimes that happens. So should not hang all your hats on that one principle. And then apparently single S2, that's because the two great arteries are front to back, and therefore one sound is not heard very well. It's far away. Therefore, sounds like it's only one. A2 only is heard, not the P2. And the murmur is non-specific. So it doesn't give you the diagnosis. And then PDA PFO allows for mixing. Sometimes they have that mixing already going, but other times we will have to create that. And if there are any associated defects like VST or PS, that's when the TGA is called a complex TGA. If they don't have any associated defects, then it's called a simple TGA. And here's and that baby was started on prostaglandin. And after starting the prostaglandin, the saturations went up to 82%, and the FiO2 can be reduced to 50%. And there was hypotension. Prostaglandin is a vasodilator, so almost always they need at least one fluid bolus to support their blood. So we vasodilate the vessel. So PGE, while it is opening the duct and maintaining the ductal patency, it also is a systemic vasodilator. Therefore, you dilated the vessels, fill them up. So some normal saline, and then transferred to our hospital. That evening, patient had a balloon atrial septostomy. PDA alone is not enough for mixing, and the satisfactory mixing happens at the atrial level. And so this is the balloon atrial septostomy. The balloon is being inflated in the left atrium across the PFO, and then it's going to be pulled through. And still in the LA, that is pulled through. Now it is in the RA. And you can, we do it under fluoroscopy, and echocardiographic additional guidance is used by transthoracic echocardiogram. And nowadays we do it at the bedside without fluoroscopy, with just echo guidance only. And after that, maybe briefly that night, patient had nitric oxide, was used because of the pulmonary hypertension that exists in all babies. Their saturation may not be adequate, so we used it for the night and then weaned off next day, extubated next morning. Prostaglandin was weaned, the SATs held at 80s in the room air, and the regular feeds were started. We give it for 4 days, and then patient went for arterial switch operation on day 6 and discharged home on day 14. So the arterial switch operation itself is something that we didn't do all the time. Prior to 1975, when Dr. Adib Jatin described this arterial switch operation, it was atrial switch operation. You didn't know how to transfer the coronary arteries. That was the key problem in doing the arterial switch. So arteries are left alone where they are, and the blue blood and the pink blood at the atrial level are switched with use of baffles inside the atria. So the pulmonary venous outflow is directed to the tricuspid valve, and the SVC-IVC flow is directed to the mitral valve, and then the pink blood is now going into the aorta. That worked very well for about 20 years. But then systemic RV, so the right ventricle is not been meant to support a systemic vascular resistance, and therefore they start to fail. And also the multiple suture lines inside the atria lead to very severe atrial arrhythmias. So the patients will be dealing with atrial arrhythmias and a failing right ventricle. It's called systemic RV. And these two are the main problems for all these patients in their 20s and beyond. But that's not seen anymore with the arterial switch operation. So here is the survival for the arterial switch operation. So the atrial switch operation is no longer done, except in a few situations where there is associated pulmonary stenosis. So here is the survival part. For the simple transposition, which is that solid line is the highermost line here. There is a little bit of attrition in the beginning. Afterwards, once you go past 6 months or so, there's no attrition after that. So the survival is very good. And this is going up to 16 years, but even beyond, not much is expected. As opposed to this natural history where when there is no surgery done for transposition patients, almost all of them die by 1 year of age. Anyone who is alive after that, they all have a VSD. Without a VSD, you won't live beyond 1 year. And one of the things somebody taught me was there's a cyanotic patient. If the patient is below 4, keep transposition as an additional differential diagnosis. If they're above 4, it's got to be tetralogy. So that's it. Between tetralogy and transposition, if they're under 4, you have to have both in differential diagnosis. After 4, yes, tetralogy is the only one to keep in the list. But that's a very simplistic way of thinking, but that's true with this natural history. So that means this picture means that I'm going to change topic to the next one. So I think, so very quickly, let's review tetralogy fellow, the other common congenital heart disease. I think there are very short time left. So there are 4 lesions tetralogy: pulmonary stenosis, VSD, overriding aorta, and right ventricular hypertrophy. But then Dr. Von Prague, one of the famous pathologists from Boston Children's, in the 70s said, it's really a monology where this conal septum just deviates towards the right ventricular outflow tract and causes all of the problems listed in the tetralogy, meaning pulmonary stenosis. Stenosis, this septum, which should have closed the ventricular septum, has just gone away and leaving a VST open. And then that deviation also brought the aortic valve to override the VST. So you got this 4 manifestations because of RV seeing systemic resistance, RV hypertrophy, and PS also contributes to the RV hypertrophy. So all these 4 items happen because of this one thing, the conal septal deviation. I'm going to quickly go through that. This is still same. Conal septum is here. You have the RV outflow tract, pulmonary artery here, and VST in this location, and aorta. The VST is overriding. Tricuspid valve in this location, RV is very thick. So these are the features of tetralogy of Fallot. And in general, tetralogy of Fallot is a spectrum of diseases. The basic 4 principles are the same, but you can have no PS on one end, where it is called a pink tet. And on the other hand, you have pulmonary atresia. So that pulmonary atresia is this end, and tetralogy without PS, which is a pink tet on the end. The typical tet is right in the middle, where you have a moderate level or severe level of pulmonary stenosis. And that's that. The clinical presentation, cyanosis, will be dependent on the severity of the pulmonary stenosis. Single S2 because P2 is loud, soft, and the PS murmur, systolic ejection murmur, cyanotic spells, and the kids who get to be older start squatting themselves because they feel better. Intuitively, they have figured that if they squat, they feel better because more oxygenated blood goes into the more blood goes into the pulmonary circulation, comes back with oxygenated blood into the left side, because the squatting increases the systemic vascular resistance. And then the boot-shaped heart in chest X-ray, right axis deviation and right ventricular hypertrophy. Here is the boot-shaped heart. What kind of boot? That's the kind of boot. In Netherlands, they use this wooden boot. So you have that lifted apex because of RV enlargement, and you can have a concavity at the pulmonary artery segment level. And this is a comparison long axis view showing the aortic valve here, which is overriding the ventricular septum. And the short axis view where the aorta is in the middle, the subpulmonary stenosis, this is the conal septum, which is deviated and created a stenosis. This level, pulmonary valve is higher up, and you have the flow acceleration starting subvalvular level, sub-PS is what is typical. So if it is a mild moderate cyanosis, patients can go home with 75 to 85. This is the sweet spot for these patients to go home. And then they will have an elective tetralogy repair at 3 to 6 months of age or so. But if it is severe desaturation, less than 70% saturation, then they have to have either, that's a decision-making process. Each institution differs in whether they do a palliative procedure like a shunt or full repair as a newborn. So the palliative procedure is a shunt, which was the original beginning of blue baby surgery in 1944. This movie actually shows this very nicely. And this is what classic PT shunt, we call it classic PT shunt to differentiate from the modified PT shunt. Generally, this is not done anymore. You take the subclavian artery and turn it down and connect it to the pulmonary artery. Thus, the pulmonary blood flow is increased, and therefore they become less cyanotic. And that led to short arms and other things, and therefore now a Gore-Tex tube is placed to create that shunt. And in the recent era, we put a stent in the PDA. So this is a case of pulmonary atresia, TED pulmonary atresia, and the PDA was kept open with the prostaglandin, and then you go to the cath lab and get a stent placed in the PDA so that that serves as a shunt. And then this is out of place. Those two structures are out of place. So this is tetralogy flow corrective repair. Important point to remember is when we call it complete repair of tetralogy flow, if the pulmonary valve annulus is small, which is the case in most cases, you have to enlarge the pulmonary annulus, and therefore a transannular patch is placed, starting from RV outflow tract across the annulus into the main pulmonary artery. That sets the patient for a lifelong pulmonary regurgitation. It is well tolerated for about 10-15 years, and then RV starts to fall apart, and therefore they need a valve placement here. Previously, we used to do it surgically, and now the pulmonary valve implantation is done transcatheter in 15-20 years down the road. But if the pulmonary valve annulus is adequate in size, the valve is left intact, and there is a patch in the lower part and another patch in the top part, then that patient can be considered that potentially not need any further surgeries or interventions. And this is the outcome of tetralogy flow patients. If you're born in the 40s and 50s, this is your outcome, then the survival really was down to 30% by 40, 50 years. But in the 2000s, there's no initial, except for the postoperative mortality, there's no further problems these years. So this is just indicative of how cardiac surgery has improved outcomes over the years, and the surgery itself is improved. This is data from Toronto. And I think I will stop here and take any questions. There are no more time, I think.
Thank you, sir.
Okay.
Thank you. That is a very lucid. At the same time, we learned about two main disorders, two main cyanotic heart diseases. So the forum is open for audience to ask questions or comments if they have. Kindly do that.
Hello, Balaguru, Dr. Ravi from Trichy. So somebody who is born now with fellow of tetralogy, so what is the life expectancy with all these procedures?
We would think that will be good. So tetralogy flow, as I said, there is a spectrum, and that modifies the answer a little bit. But a typical case of tetralogy flow, we would expect them to have a normal, within quotation marks, normal lifespan. Along the way, they may need another reintervention, a pulmonary valve implantation. Sometimes they develop arrhythmias, ventricular tachycardia from that scar. And that can be eminently treated. So these are two things that will modify the outcome a little bit, but they will be expected to have normal lifespan. I will just show you one other slide here, this one. This is the success story of congenital heart surgery outcomes. So this is a complicated one, but I will go over it just in 30 seconds. So this is from Quebec, population-based study from Quebec province, and they just looked at compared the mortality reasons for patients over the years and what proportion of deaths were attributed to congenital heart disease. And the age group is in the middle, and then 1987-88 year outcomes are one side, and the year 2004 to 2005, so that's about 20 years gap. So less than 1 year age, 27% of deaths were due to congenital heart disease. That has come down to 4%. Then it keeps going. Everything is diminished by age between these 20 years. And then if you go to this older age group, adult age group, there were not many deaths from congenital heart disease. That's because they did not live this long initially. And then on this side, they are living, and then they have their congenital heart disease diagnosis listed in their death certificates and all that. Therefore, their cardiac deaths are starting to show up. Congenital heart disease, not cardiac deaths, congenital heart disease deaths. Whether it is because of that or not, this is just the death certificate data. So this is a sign that they are all living into adulthood. because of the success of surgery in this. So yeah, we would say we will quote 3% mortality for tetralogy fellow, expecting 0% immediate for counseling patients pre-op.
Thank you, Balaguru. You know, because we had somebody in the family, some persons in the family we know who had this tetralogy of Fallot, and then we would definitely be happy that mortality is definitely has come down and treatments are available. Better treatments are available. One more thing is I noted that there are situations where there are no prenatal checkups. I saw there is when you presented that 1 year, 1 day child. There was mention it's a rural case with no prenatal. So that was really surprising.
Right. Yeah, you still see such patients. It's also cultural. There are groups of families that live in some areas who deliberately not go to the doctors.
Okay.
Exist. So that's
Thank you, Balaguru. Excellent. Thank you.
Balaguru,
yeah.
You have been working in Boston. Boston Children's Hospital made ripples in the beginning of cardiac surgery by one Dr. Subramanian. He did neonatal cardiac surgery under total circulatory arrest with a deep hypothermia. Before cardiopulmonary bypass was in full swing, when Lily Hay was doing mother circulation for baby, he was making revolutionary efforts in closing VSTs under a total circulatory arrest. Can you share Subramanian's photograph if you have?
I don't have it.
Have you heard of him in the Boston halls?
No, I have not, but it's probably just because of my ignorance. But I think Dr. Subramanian, was he in Albany?
Long ago. When cardiac surgery, when Lily High and when other centers were initiating cardiac surgery with a cardiopulmonary bypass, he was doing under total circulatory arrest.
Right. Yeah. So John Lewis in Minnesota, before Lily High, just is 2 years ahead of him in 1954. That's the region when John Lewis successfully closed the ASTs using only hypothermia in Minnesota. And probably that's the time everybody tried that. Gibbons in Philadelphia also did that. And John Lewis took the principles from Gibbons and did it. And I don't know. I will look for some record in little bit.
Sure. And what are the results in pulmonary atresia? The surgical results in pulmonary atresia in your centers, and what do they do?
So that's a very loaded question. You're asking a very important question. Pulmonary atresia, the outcomes and are variable depending upon the nature of the pulmonary artery anatomy. So it's not the cardiac part, it's the pulmonary artery anatomy that decides the outcome. That complicates the repair as well. So what it is this pulmonary arteries, if you have native pulmonary arteries that are confluent, meaning right and left pulmonary artery come together, then it is easier to put a RV to pulmonary artery conduit and start the circulation go forward. But in patients who have discontinuous PAs, you have aortopulmonary collaterals that supply the lungs. And that is the exclusive source of pulmonary blood flow to the lungs. And there are 4 or 5 of them. And you have to bring them together, unifocalize them, make them into pulmonary arteries, and then ultimately connect them to the heart. So that is the step-by-step process. So staged repair will be done. And that is what is generally done because the limitation is the surgeon's experience. Bringing all of them together in one go, in one step, is harder. And therefore, they do thoracotomy on left side and do this. And then right side, they do the unifocalization. And then third surgery is sternotomy and connect them all together to the heart. And then sometimes these vessels are not adequate so that the VSD inside the heart will be left open as a pop-up for the right ventricle, and then that can be closed either in the cath lab or in the OR as a fourth surgery. That's the staged procedure. That will take about 2 years, 3 years. But the one who is doing it all in one stage is Dr. Frank Hanley in Stanford. He just unifocalizes all of them, puts the RV2PA conduit. He may leave the VSD open in that first sitting. And that takes 12 hours, 16-hour, 18-hour surgery. And he's the one who shows very good results. So here it is a combination of sometimes staged, sometimes straight cases. So it is the patient's baseline saturation that determines whether we wait for a one-stage repair at 6 months or 7 months. If they are bigger, that's better. So 6 months, 7 months is bigger. But if you have to intervene during newborn period, we just generally put a PDA stent or a BT shunt and then wait and then do it. Then it becomes a staged repair. So it's a combination. Yeah, it varies from patient to patient.
Balaguru, what is the ideal age for total repair in TOF?
Tetralogy ideal age is 3 to 6 months. So there have been people who really went neonatal repair of tetralogy fellow. The results were not good. So we all did it and then we reverted back. 3 to 6 months is our ideal age. Sometimes later, sometimes sooner.
Balaguru, can you elaborate on congenital myocarditis?
Yeah, so that usually will be some infection that the mother had. So viral infections are the commonest ones. And you have a large heart and failing. And when they are born and they have this kind of picture, all options are open. It can be dilated cardiomyopathy from metabolic disorder, inborn errors of metabolism. It can be dilated cardiomyopathy from infection. Those are the two things that we have to rule out as a newborn. And the treatment, so you immediately do various types of troponin check, but that's not specific in this kind of situation because troponin is elevated in normal newborn. And so you give them IVIG, assuming that it is myocarditis, and then the results come back in 3 days' time. Sometimes they end up requiring ECMO. If they go on ECMO as a newborn, the outcome is really poor. If they don't need ECMO and just intubation, ventilation for heart failure support, and then they improve in the next few days, and when the pulmonary vascular resistance drops, such patients have a better outcome. So that's all. It's just not common. We just see one here, one there, once in a few years.
The ideal age for DAPV is a correction, Balaguru.
DAPVR?
Yeah.
It's when you find it, you repair it. So if you found it at 5 days of age, you are going to repair it at 6, 7 days, 8 days of age, depending if they are fit for surgery. Otherwise, you wait until they stabilize and then they go. So DAPVR, it is they are going to present when their ASD becomes insufficient. If you think about it, I have a picture in here. So sometimes they can present at 8 weeks. So whenever we find them, we repair them, no matter what the age of the patient is. So repairing it as a newborn is a little bit difficult. Sometimes in some situations, if everything is suitable, some surgeons, I have worked with some surgeons who have waited until they are 6 weeks old. For that, they have to be stable. The ASD is the one that determines that. So here is so we should use this analogy of if you are an RBC, you are coming into the heart. Where are you going? Is the TAPVR that's useful. So you are coming in. So let's take one example. This is 3 types of TAPVR here. Supracardiac type, where the pulmonary venous confluence is behind the heart and did not open into the left atrium, and it empties through a vertical vein on the left side and it comes around and joins here. If you are in this location, you go into the RV and go back into the pulmonary arteries, and when you return, you are not returning to the heart, and it just goes through here. And then you have the systemic venous return coming into the, so right ventricle receives all of the blood, pulmonary venous return and systemic venous return. You have to have AST that is adequate size to fill the left ventricle. So left atrium, left ventricle does not have a source of blood flow in this situation, unless, except for the AST. So you have an obligatory atrial level shunt. And so you have that. If that were to be adequate, sometimes these patients go undetected until 6 weeks, 8 weeks. So that's so they can be operated then. If they don't, and then that's one part. Second part, they can get obstructed. Supracardiac type will get obstructed in between the left pulmonary artery and the left main bronchus. Cardiopulmonary, bronchovascular wise, it is called. Obstruction will make you immediately operate. And then the infracardiac type almost always goes to the portal vein, and therefore it is by nature is obstructed. The cardiac type never gets obstructed, general rule. So you can wait a little bit, few weeks, and then here it is dependent on the obstruction, presence or obstruction or absence of it. You don't always have obstruction here. So yeah, 6 weeks. Because one of the things is, when you repair TAPVR as a newborn, you may have to go on circulatory arrest, deep hypothermic circulatory arrest that Dr. Nilakandan sir mentioned. That's still being used, deep hypothermic circulatory arrest. It's not the same way as it was pull them down and then take them off and then go and repair this. So that is quite morbid, even in this day and age. And therefore, some surgeons may choose to wait until 6 weeks, 8 weeks. Maybe that's it. That's the usual time.
Wonderful presentation, Balaguru. From a community health perspective, anything is being done in India. Maybe if you know, you can tell, or the cardiologist from India, because I heard, not very sure, that Kerala has a scheme where they pick it up early, and at whichever level it is, there are philanthropies, and through telecardiology, bigger centers are involved, and the children are shifted to centers where they can be operated quickly. So early recognition and intervention early, irrespective of the economic status of the child, that is crucial for successful outcomes in a country like ours. So I think Tamil Nadu and Kerala being at the forefront of healthcare, are there any schemes available in Tamil Nadu for this?
Not in Tamil Nadu. I only heard it from KK. KK is Dr. Krishna Kumar in Amrita Institute. I've known him for a long time. He was my teacher's classmate in Boston. He trained in Boston. He's from Ames, Delhi, and came to Boston Children's, and he trained at the same time as my teacher in NYU. And because of that association, and then subsequently, I know him for all these years. And he started this, and from what I heard from him, the infrastructure created in Kerala is really good. When he describes, I'm thinking, oh my God, is it really possible in India, in the Indian setting? And he has made it work. There is somebody on call. There are a network of people that they can call nearby and make them prepare the patient for transport, all of that. And it is definitely very nicely set up as Amrita Institute, as the apex institution for that, all of those patients coming through. But I haven't heard something similar from India, from Tamil Nadu.
In Tamil Nadu, 10 years ago, Ilam Chirar Idayam Kapam Tittam was there. Okay. I happened to operate a couple of cases in my center, valve case, and I had a chance to operate about a dozen babies in Kadalur Hospital. That scheme was called Ilan Chirar Idayam Kapam Tittam. But all those plans have been amalgamated into chief minister scheme, insurance scheme. So now there is no problem for surgery. Everywhere center is there. Many surgeons are there. And the one thing is you have to make a echocardiogram mandatory in all children, or suspected children. So early diagnosis is very important.
Yeah, diagnosis. Yeah, coming to the attention of someone with echo skills to do it.
So even in Trichy, in Hindu Mission Hospital, we were getting from Tambaram Hindu Mission Hospital, a doctor is used to come once a month. They carry the echo machine, and then they were conducting camps. So individual hospitals do it at the secondary level, secondary or tertiary level. So that's been done.
Yeah, at the primary level. Yeah, I remember Dr. Neelakandan sir, I saw him in 2010. He came and operated in KJ Hospital in Chennai. I came there on a mission trip, and he operated with a surgeon from US in our team. That's when I last saw Dr. Niels, 2010.
One of our alumni, Dr. Gopi Nalayan, I just know him through Facebook. I think he's doing good work near Madurai. Earlier, he was in Raipur or somewhere in North India, Chhattisgarh, I think. Then he shifted along with his wife to Madurai, and they've started some philanthropic setup where they operate poor children free of cost.
Yes, yeah, I've heard of him too. I forget the name of his organization. He's doing a good job. One of our echo technicians from Boston, she went back to India and worked with him for a couple of years and returned. So yeah, he's doing a good job. She says very good things about him, speaks very highly of his organization.
In Tanjore itself, we have got a tiny heart center managed by Maniram Krishna, who is son of our alumni, Dr. Singaravelu, pediatrician. He is doing wonderful work in Tanjore. He picks up a lot of cases of congenital heart disease at an younger age. And he is doing a fantastic job. And he was also trained by KK from Amrita. He himself arranges for the poor children the money that is needed for surgery, and he himself takes the patients to Kupsami Naidu Hospital, Coimbatore, for any surgical correction. Otherwise, for non-interventional cases or non-surgical interventions, he himself does in Trichy, Kaveri. He is doing a wonderful job in Tanjore.
That's good, very good. In Kaveri Hospital, I see the name.
Dr. Gopi Nalayan's organization is called Little Moped Foundation, Heart Foundation.
Yeah, right. Yeah.
This is Tiny Heart by Dr. Maniram Krishna in Tanjore.
Good to know. Yeah.
If there are no further questions or comments from the audience, can we call it a day?
So I have one last question. I'm Dr. Lalita from Coimbatore.
Go ahead, madam.
That was an excellent presentation. I just had one doubt. Regarding one first child with coac, you had said the baby had developmental delay. So do you look for, genetic conditions like, do you actually do a prenatal or a postnatal analysis for these kids? Because we have quite a few prenatal detections, and we do an amnio, and we detect associations like 22q1 1.2 microdeletions and all that. So what is your experience on that, sir?
Good question. Yeah. All patients with congenital heart disease undergo genetic testing in general, overall answer, but it is not uniform. I have been in 8 different centers in this country. Not in this country, 6 centers in this country, and then 2 in England, Oxford and Great Ormond Street Hospital in London. The practice varies from place to place. in one place we had an NIH grant going, and therefore we did it for all patients with congenital heart disease. And there is some, you get these 22q11 is the commonest one that gets picked up. Otherwise, you just find some mutations that is not described at all in literature. It becomes the VUS, a variant of unknown significance. And that can become a variant of known significance in 5 years' time. So everything is kept in the record and followed and all that. That's something we did in New Jersey when I was there. I was just there for 2 years. So in principle, we do it in all patients, and it may come back negative. And then one of the other parts of this is if you did something this year, 5 years from now, you may find a mutation you didn't look for. So, and that 5 years ago, 10 years ago. So that's another thing. Yeah. In principle, I think all congenital heart disease patients should have genetic testing. Antenatal also, it's done. So we know many patients well ahead of time, everything about their other anomalies, non-cardiac, as well as the syndromic diagnosis. Yeah. I think that's something that's going to help. We don't know what we will do with that. It's similar to what happened in the 1930s, 1920s. People who were studying congenital heart disease, they didn't know what they were going to do with that study. Dr. Maud Abbott, that's the person who first classified them as cyanotic and cyanotic heart disease in 1936. She published that atlas. And that's the first time anybody just put them all in one category or other. At that time, it was just a curiosity. There was no treatment. And then now, so I think we should just keep looking. And then some 20 years, 40 years down the road, we may have some kind of genetic answer for these things.
Thank you so much, sir. The thing is, like, the challenge when we detect them antenatally is the counseling part. Like, if you have somebody like you who's like talking to them, then it's fine. But when they come back to the obstetrician and then they ask us, is my baby going to be completely normal? This is a tricky question because as you said that baby, when I was noticing the baby had developmental delay, they're going to come and blame the obstetrician. You didn't tell me this before, then otherwise I would have terminated this pregnancy. So it's like when something is detected and it's correctable and we want to proceed with continuation of the pregnancy, and then we don't want to face something which we don't know. So it's actually a very tricky situation for us.
Yeah, yeah, actually, this is the key point that you made just now, that counseling part. So in all of the cardiac centers, this is good for cardiac centers. It's harder for the non-cardiac centers. If there is a fetal echo available, that center has it in general, the counseling part. And in almost every place I have been in, there's a team. Once there is a cardiac diagnosis of a cardiac defect made, the fetal echocardiographer, they are all well versed in it. Neonatal ICU doctors and the cardiac surgeon, all three of them go and see them. Social worker is also involved. Palliative care person is also involved these days at that stage, antenatal stage. That I thought, oh yeah, what are they doing? But there is a role for them to just prepare themselves, and then when they come back to meet the family, when the baby is born, it doesn't seem unusual for them to be there. So they have actually put the baseline information in the minds of the parents. So yeah, that counseling is important. That team has to be cardiologist, cardiac surgeon, neonatologist, the future doctors, basically, and then social worker and palliative care doctors.
Yes, sir. True, because the person who counsels the patient first makes a big impression on them.
That's right. Yeah, their attitude, the way they put it across, even saying one sentence really sets the stage, right?
Yes, sir.
Now we have good geneticists also, dysmorphologists, geneticists. Dr. Sujata and her team, they are doing a wonderful job in Chennai.
That I forgot to include. Yeah, geneticists are also part of it because you do the various types of things, genetic testing. Amniocentesis is one part, looking for the cells in the maternal blood itself and doing things, various ways of doing it, and therefore they are intimately involved.
Thank you so much, sir. It was very informative, and we look forward to listening to you again.
Okay, thank you.
Maybe last question, if you are not hungry to go. Balaguru, have you tried umbilical artery or umbilical vein for catheterization on the day of birth in suspected? Because they leave the umbilical artery catheter and venous catheter for infusions. But have you tried for the intervention?
Yeah. I've done pulmonary valve ballooning through the umbilical vein. I have stented.
Fantastic.
AST. So in a hypoplastic left heart, AST stenting. Of that kid, we took the patient right from the delivery suite to the cath lab, put the UV line ourselves, and went on 20 minutes after birth.
Excellent. Okay.
So yeah, whenever it is available, the one word of caution about using umbilical artery for umbilical venous use is more straightforward because it is straight up course. Of course, you have to negotiate the ductus venosus and get there. It will happen by itself. If not, we take angiograms and then find the ductus venosus and go. Umbilical venous catheterization is easy in the sense there's no turns. Umbilical arterial. So for aortic stenosis, we've done some cases of aortic stenosis ballooning, but that one is fraught with problems. I've seen problems happen in others cases. So I try not to do it through the umbilical artery because you have to take a U-turn in the umbilical artery. It goes down and then joins the common iliac and then goes up. And then you take a U-turn at the arch, get into the aortic valve. And that's the crossing the aortic valve in aortic stenosis is the main technical stopping point in your procedure. Once you cross it, the procedure takes 2 minutes after that. So aortic stenosis ballooning. And so I do it through femoral artery. Because of that turn, sometimes the tip of your sheath can actually tear. That's what I have seen. It has torn at the turning point.
So joins the internal iliac artery. So there is a bottleneck.
Yeah, that's the key part. And then manipulation of the catheter tip to cross the aortic valve in the retrograde direction. The jet is coming forcefully at you, and you are trying to put your guide wire in the middle of that opening to balloon this stenotic aortic valve. That manipulation, the finer manipulations are difficult because if you have a turn at the bottom and turn at the arch level, it becomes harder. So, and also riskier. So I try. So that's the word of caution about using the umbilical artery. If you're just going in to get one angiogram in the arterial side, you can use the aortic umbilical artery, but technically involved, ballooning, stenting, those things, I would avoid umbilical artery.
Thank you.
Are there any more questions? I think if there are no further questions, sir, thank you so much for giving us a lucid lecture for this day. We are hoping that we will have a part 2 as we agreed upon, basically on cyanotic heart disease as well. So when you find time, probably we'll have a part 2 as well. And I'm already getting a lot of messages. People are asking other cardiac ailments as well in pediatrics. So they want to infectious problem in the heart, autoimmune conditions of the heart, Kawasaki's disease, individual topics they're actually asking. I'm getting quite a lot of messages. So probably we should schedule something in the future, and we will probably discuss about this in the future as well. So thank you so much. Thank you all for attending the talk. And as usual, And I mean, I'm happy to say that we are we have done the 10th TMC Medalog today. So our 11th edition will be on October 10th, and that will be from Dr. Captain Dodd. He'll be talking on burns. So please look forward to that talk as well. And I hope that most of you will join for these talks in the future as well. Thank you so much. Good night to each one of you. And the recordings will be made available as early as possible. Thank you.
Thank you. Enjoyed it. Thank you.
Thank you for the opportunity, sir. Thank you.